It is my great pleasure to introduce the Mortensen lecturer for this year. This is a very, as I say, prestigious lecture that has been going on since the inception of the Association of Surgeons. It's awarded between the English College, actually, and in consultation with the Association of Surgeons of Great Britain and Ireland. Mortensen, of course, founded the ASGBI. He founded the British Journal of Surgery. He became the president of the Royal College of Surgeons of England. He was professor of surgery in Leeds, where I did some training, as did our president of the ASGBI. I note that our lecturer, Professor Mortensen, is talking about legacy. One of the legacies that Mortensen, I wish, had left behind was the fact that he used to come down to London for 3 days a week. And part of the reason was because he ran his private practice in London. And the train from Leeds to London used to wait till his personal carriage was put on the train. I wish that legacy still holding. I think that's a nice tradition to uphold. We come now to the introduction of Professor Mortensen, who is an very old friend and colleague of mine, who I think I met 36 years ago, actually. I was just calculating that, Neil, when we both were young and virile, and sadly to say, there's only one of us in that condition now, and I won't tell you who that is. Neil has had an illustrious career. He stayed in Bristol and was a senior lecturer and consultant there, and then moved off to Oxford, where he developed his department of colorectal surgery and became professor of colorectal surgery in Oxford. He's contributed significantly over the years in all parts, as it were, of coloproctology, and particularly in the field of the surgery of inflammatory bowel disease. He's been past president of the Association of Coloproctology. He's president at the moment of a major patient support group, Ileostomy Association, and also chairman of the British Journal of Surgery, amongst many other duties. He's made a superb contribution to British surgery, and he's going to give a very interesting, I'm sure, and insightful lecture. And he is a really, truly wonderful lecturer, and I'm sure you're going to enjoy this. And the title is Legacy, a Dirty Word, Lessons from Surgical History. Professor Mortensen.
Well, thank you, Norman, and thank you, John, for this very, very great honor you've bestowed on me. The title is cryptic, but I hope I will give both an entertaining and a slightly controversial presentation. Those of you who know your aeroplanes will see that that is a modern legacy. I'm afraid I don't have one. So I'm going to say a little bit about legacy. I'm going to say a little bit about Moynihan. I'm going to say something very briefly about political legacy and how it differs from ours. I'm going to say something about Halsted and his cancer theory. I'm going to talk about the battle lines in colorectal surgery, and particularly for rectal cancer. And then I'm going to say a little bit about the future. So legacy is defined in the Oxford English Dictionary as anything handed down by an ancestor or predecessor. And of course, this isn't qualified in any way. It can be good or indeed bad. Now, Norman's already mentioned Lord Moynihan. This rather fine oil painting is actually in his office at the Royal College of Surgeons at the moment. And in the statutes of the College of Surgeons of England, the Moynihan lecture is described as having been founded in 1936 to the Royal College of Surgeons of England a legacy or sum of £2,000 for the purpose of founding and eponymous lectureship. So there's an example of legacy straight away. It also says towards the bottom, an honorarium may be given at the discretion of the president, and then rather darkly after that it says an honorarium hasn't been given in the last 10 years. Of course, part of Moynihan's fantastic legacy, as well as the Association of Surgeons, is the BJS, as we now call it, then the British Journal of Surgery. He and Haygroves in 1912 dreamt up the idea of a surgical journal for the British Isles, and in 1913 it was first published, and next year we will be celebrating the 100 years of the British Journal of Surgery, and it's been my great privilege and a great deal of fun to have been associated with the BJS in one office or another for nearly 25 years, and I've just demitted as chairman. Moynihan, I think, would have been absolutely delighted to see the progress of his little baby, as it were. It's now obviously a world-class journal with enormous influence on surgical outcomes and practice and patient outcomes. Now, many despots, leaders, kings, queens, and politicians, of course, have been very keen to ensure their legacy. And I'll just take one example. When Tony Blair was swept into office in 1997, it only seems like yesterday, there was a great deal of hope and expectation, soon to be dashed, as with many elections of new prime ministers, in the world of spin, of controversy, and especially the war in Iraq. And so much so that I think when Tony Blair left office, there wasn't really much legacy to talk about, and he's desperately now working around the world to try and secure it again. What about us surgeons then? How can we, and as I've been coming towards the end of my career, I've been musing a little on legacy, not for one moment thinking that I'm likely to leave one in any kind of way at all. But of course, surgeons can leave some money for a lectureship or something like that. You can be lucky and have a disease, an instrument, a book, a department, or even a building named after you. You can have an operational technique named. Or, I think for most of us in the more humble surgical world, we can look back on having done as well as we possibly can have done for our patients, colleagues, and trainees. Now, I've just finished reading this excellent book, which I suggest you might have a look at, by Gerald Imber, Genius on the Edge, about the life of William Stewart Halstead, who remarkably managed throughout his surgical career to conceal his morphine addiction. Every afternoon he had to leave the operating theatre or the research labs, and nobody knew where he went, but he was going off to get his regular fix. He, of course, has left a remarkable legacy, being one of the founders of Johns Hopkins University. Here's the famous picture called The Four Doctors by John Singer Sargent. It was actually painted in Chelsea in 1906. We've got Welsh on your left, we've got Osler, and then at the back is Halstead by the Globe, and on the right, Kelly. Osler at that time by now had become one of the most famous physicians in the world and was Professor of Medicine, the Regius Professor of Medicine in Oxford. Many feel these guys were the fathers of modern medical teaching, certainly in the United States, and they laid the foundations for modern postgraduate training, the residency ideal of surgical training, and then the notion of combining research and training and teaching all in the same department. One of his other legacies, of course, was the notion of the so-called Halstedian theory of the spread of cancer, which became almost a godlike, iconic symbol of surgery for the next 50 or 60 years. The big operation to get rid of the cancer was the only way to go. He believed in an orderly progression of cancer spread, which could be easily encompassed by making the operation bigger and bigger. And that was why, obviously, in those early days, radical mastectomy was the way to go in breast cancer surgery. But despite this, 20% of patients with early disease died in the face of what seemed like adequate local control. Well, 50 or 60 years later, the worm turned, And here's a lovely picture of Sir Hedley Atkins, an oil painting in front of Down House, previously lived in by Darwin. And he promoted, amongst others, this is a gross oversimplification of the management of breast cancer, and I do apologize to the experts in the audience, but he, amongst others, promoted the results of North American studies showing that if you compare mastectomy with conservation and radiotherapy, at 15 years there was no difference in survival. So the idea of tailoring treatment at last began to take hold. No longer the huge mastectomy, the axillary dissection, all the morbidity, smaller operations, eventually ending up with lumpectomy and nodal sampling for the fortunate few. But to be fair to Halsted and his legacy, at the time there was nothing else. These were the glory days of surgery. And if you read the book, it is absolutely incredible. All the firsts in lots and lots of areas being done around that time. It was an amazing time for the growth of surgery. And patients, of course, presented very late. Their tumors were huge. There wasn't anything else. They didn't have what we now have, the huge advances in chemotherapy and radiation therapy since then. Now, in colorectal cancer, the battle still rages, of course, and I suppose our modern icons for the management of colon and rectal cancer would be Bill Heald and Werner Hohenberger. They're our modern Halstedians. Only the big operation, completely removing the whole lymphatic package, will do. There is no other alternative. And this is despite the evidence from cancer biology that there are already micrometastases present in many patients, even with small tumors, the variable biology of cancers, some growing fast and slow, the advances in chemo and radiation therapy, which we see rapidly all around us, and in the change in the nature of the problem we're dealing with screening. And whilst there have been huge advances in reductions in mortality, recurrence rates, and cancer-related deaths, morbidity and function stubbornly remain a problem. These huge operations, which we love to do, have an underestimated morbidity, which many of you will be familiar with. Stoma rates, readmission rates, morbidities in the long term too. And of course, it may be appropriate for a very young patient to have the big operation to ensure longevity. It might not be appropriate for our aging population, increasing numbers of 90 and 100-year-olds, to have the big operation. They're interested in quality of life, not necessarily length of life. And here is one of the effects of modern medicine, that is screening on our business. Here are some figures from Bob Steele and the early days of his Tayside screening. You can see there, stage A tumors now, 49% of cancers are early cancers in the prevalence round and 40% in the incidence round in the National Bowel Cancer Screening Project. Small tumors in fitter patients and older patients don't necessarily need the single solution to their problem. Now, of course, there have been alternatives to radical resection since the turn of the 20th century. And some of these names have become famous names with a legacy that you'll all remember. I'm going to first of all just mention one of these, York Mason. Now this is actually, if you've never seen a York Mason, the beginning of a York Mason operation. It's from some Super 8 film, converted to digital, and it's actually Aubrey York Mason himself doing a York Mason operation. I'm obviously not going to show the whole lot of it. The patient is face down, and you can see on the right-hand side what he's attempting to do. He's going to make an incision slightly to one side of the coccyx in the sacrum and extend that right through the anal sphincter and lay it open like a book in an attempt to get access to the rectum in a more minor way than doing a huge abdominal operation. And this is a wonderful bit of traditional surgery, the Swan Morton blade, making an incision, and York Mason himself, if you've never ever seen him or heard of him before, this is one of the early operations for getting access. Still, we use the term a York Mason approach, actually doing the operation himself. Now, one of our other icons was, of course, Sir Alan Parkes, who gave his name to the peranal excision of tumours. Here's a lovely textbook picture of an excision of an early cancer, but of course, actually gaining access so easily is often impossible in big patients, and although it looks dead easy, in fact, it can be incredibly difficult. At the same time, there have been massive advances in fibre optic technology, and here is endoscopic mucosal resection, the polyp raised on a saline cushion and removed across the submucosal plane, and this can be done for some early tumours too. In 1993, Bob Steele, Mike Hirschman, and myself introduced transanal endoscopic microsurgery in the UK. It's, if you like, one of the first single-port operations there have been. It is a true NOTES operation. And here you can see the 4-centimetre eye-wateringly large scope in the rectum. And here's a little bit of a clip of 5 times magnification CO2 pneumorectum, minimally invasive keyhole type surgical instruments through gas sealed ports, and here's a lesion in the rectum being marked out, and then the surgeon will join the dots together. Mostly we look on the TV screen these days, but you can look down an optic which gives you a little bit of 3D depth perception, and you can see that the operation here is actually quite dynamic. The scope's being moved around to get to all aspects of the lesion before removing it. Now, of course, this kind of approach to cancer is highly controversial. Another great icon of colorectal surgery who's left a legacy in his fantastic book, which Norm Williams still edits. In this edition on cancer, he said, sometimes in the management of frank ulcerating carcinomas of a relatively localized, apparently favorable kind, in the lowermost 8 to 10 centimeters of the rectum, particularly in poor risk patients, or in those who have refused rectal excision because of their abhorrence of a colostomy, treatment by local excision may be considered, though this is a highly debatable issue. Well, as late as 2000, from Minneapolis, there were these figures on local excision, which kept the argument bubbling along. Here you can see for T1 cancers, local recurrence figures of 14% compared with 3% for classical surgery, and for T2 tumors, 38% compared with 5% for classical surgery. But interestingly, no impact on survival. I like this quote from David Rothenberger. It said that misery loves company. For a time, we stood out as the only group reporting such dismal results, and we wondered whether we would ever have that devious distinction forever. Well, at the same time, in the National Cancer Database in the United States, between 94 and 96, there were 765 local excisions for T1 or 2 tumors on the database, and their local excision rate had increased from 27 to 44%. There was a 30-day morbidity of 5 versus 14%, local recurrence rates of 12 versus 7%, and no difference in 5-year survival for T1 tumors. A publication around the same time in the BJS from Sweden, a fantastic Swedish rectal cancer registry, 643 patients that had a local excision, cancer-specific survivals of 95%, local recurrence rates of 7%, similar outcomes to classical surgery, particularly used in those with high comorbidity or the elderly. Now, our national guidelines with the Association of Coloproctology at the moment are that local excision for cure should be restricted to T1, well or moderately differentiated tumors less than 3 centimeters in diameter, and subsequent histology may identify a small group requiring more radical surgery. Now, for TEM, for local excision for early rectal cancer, there are a large number of reports of cohort studies now, and in the top there are some of the most recent publications. And I'm going to say a little about the STARD group, the biggest series of TEMs for local excision for rectal cancer, published by Bach in 2009. And this was an example of a wonderful surgical network, research network, if you like. We started the TEM users group, and everybody started putting their figures together to see where it would go. 424 patients, 253 T1s, 138 T2s, an overall morbidity of 15% and mortality below 2%. And here you can see, if you follow the UK guidelines, in the top dark line, T1 tumours less than 3 centimetres and so on, a local recurrence rate of only around 4 or 5%. If you disregard the guidelines, local recurrence rates rising to 20% or more. If you're very, very selective and choose the best, small T1 tumours with no lymphatic invasion, well or moderately differentiated, you have a negligible local recurrence rate. And even better, if you use TEM as a big biopsy and you decide the patient needs more, I've used the term early salvage surgery here. Perhaps it should be completion surgery. If you do a TEM followed by a TME, you have, for both T1s and T2s, a negligible local recurrence rate. And other centres have come up with similar figures. This study from a German group, low-risk recurrence 6%, high-risk 20%, with a median of 74 months. Now, of course, the problem here is the lymph node, and the future will be the assessment of nodes in a better way, and there are now some proposed trials at last to present us with some data about local excision. Things are moving on. Here is the study of Lezoche, 70 patients who had T2 tumours, low in the rectum, some treated by local excision and some by laparoscopic TME. They had a preoperative long-course chemoradiotherapy regime, 2 local recurrences in the TEMS, 1 in the lap TME, distant metastases similar, probability of survival the same. Not just local excision plus. And there's growing evidence, of course, for the power of downsizing and a complete pathological response by chemoradiotherapy. Habragama's studies showing a watch and wait policy for some of these tumours. Better outcomes and overall survival in those having a good response to neoadjuvant chemoradiotherapy. And in this study in the Annals of Surgical Oncology in 2011, now T3 tumours, 26 patients having a CPR treated with a local excision of the base or the ulcer left afterwards, did as well as those having a TME. Chemotherapy and radiotherapy are obviously clearly not standing still, and they're improving all the while. Now, this is going to be a very difficult study. This is a UK randomized trial of radical surgery versus an organ preservation strategy with short-course radiotherapy and then a TEM of the base. There are, of course, about 40% of our patients who seemingly have a benign lesion who turn out to have a malignant lesion. And for these, there may be another alternative. This is being worked up. This is Chris Cunningham in Oxford. This may be a trial that flies. It's the TESSAR trial. And essentially, if you're one of the patients in the middle here with a medium risk rectal cancer, having agreed for follow-up for the low risk or a TME for the high risk, you're randomized to either adjuvant chemoradiotherapy or radiotherapy, that hasn't been decided yet, or completion surgery. So it'll be after my practicing lifetime, but eventually there will be evidence from randomized trials for these local excision strategies. So although currently Heald and Hohenberger may be the icons in colorectal cancer surgery and think their legacy is secure, it may not be. I think TME will actually decline. Organ preservation strategies will increase. Treatment will become more personalized for individual patients. And we may even tailor our treatment to the famous Vogelgram here. We may even get into the whole business of matching our therapy to the molecular biology of the cancer as it progresses through its various stages. Now, of course, surgery won't stand still either, and here's a little flavor of us working with Intuitive to try and develop robotic TEM. This is actually some work in effectively an operation theatre laboratory, and our patient in this particular example is a cadaver, a fresh cadaver, in what we've called the whoopee position with one leg raised and the other leg down. The easiest position is face down. And I'll just show you a little example of this just now. These are the ports going through the anal canal, and these are of course, the advantage of the articulated instruments down a very tight tunnel. This is actually a face-down patient. You can see the rectum going away and downwards in the distance. And at the moment, we're just playing with the instruments to see how we can get on with lesions on the lateral side of the rectum. We're just saying, well, okay, we could get to something there. That would be all right. And obviously, we can get to something on the front wall of the rectum very easily because that's dependent in this patient. And you can see here, here's the robotic example of that same tattooing or marking out of the lesion I showed you for conventional TEM. Of course, there are many advantages potentially of robotic surgery. As in single port surgery, the instruments are actually crossed and the robot can deregister that crossing to make it seem as you're using the same side hand. The crossing gives more access and room, and here you can see there's absolutely no bleeding at all with this brilliant operation, but of course there wouldn't be, would there? Because, as I said, it's a cadaver. It allows a very, very beautiful, clear, precise operation in a very tight space, and who knows, the TEM surgeons of the future may all be using robots before long. And of course, not only for the excision of the lesion itself, just seeing completed here, and the yellow fat of a full thickness excision in the depth, but eventually the actual suturing is made much easier, as you'll just see a little snippet of in a moment before we nearly finish. There's the completion of the lesion, a nice full thickness disc excision where we send to the pathologist. We'll be able to tell exactly how far through the wall of the rectum this tumor has reached. The specimen's retrieved, and then the setup is organized for suturing. Suturing in an ordinary TEM is devilishly difficult. With the robot, it's obviously immeasurably easier with the articulation of the instruments and so on. This is also very exciting. We've talked about the problem of identifying lymph nodes. This is a patient whose tumor has been injected nearby with indocyanin green, and we have a laparoscope which can switch from ordinary red-green to the, if you like, focused frequency of indocyanin green, and we can flip the laparoscope just like that in theatre from this to the picture of, as you saw there, the nodes, and then back to red, green, blue again. So we will be able to identify the nodes draining a particular lesion and perhaps, hopefully, take it out and in theatre with something like OSNA, immediately interrogate it for the presence of cancer or not. It's just round the corner. So the problem for us is, and our notions of legacy, is the problem of our rapidly changing environment. Society changes, patient preference changes. Older patients don't want the morbidity. Medical advances change the needs. Screening is making a dramatic impact on the kind of things we do. Technology is also rapidly changing the things we're able to offer our patients. Now, political legacy may be a dirty word, and these two guys on the right are now smudged out in the rapid passage of history, and I doubt many people will remember their legacy, except perhaps Bonga Bonga for Berlusconi. I don't think legacy is a dirty word in surgery, but we all have to remember it's very, very evanescent. For most of it, it'll be short-lived. I don't think legacy can be sought after. In a sense, legacy is born, not made. Think, for example, of the great operations for gastric surgery, now no longer. Highly selective vagotomy, gone and binned in history. Think of St. James's Balham, a hospital given over to gastric surgery, Norman Tanner and John Kirkham. Brilliant surgeons, many, many people trained there. Now, St. James's Balham has been knocked down and it's a block of flats. How quickly things change. And the techno-rush will sweep away many of our previously long enjoyed pet operations. A very privileged few of us, I think, will have a longer-lasting legacy, but it'll probably be by good fortune rather than anything we sought to do. Lord Moynihan, by contrast, has left a most amazing legacy. The association, the BJS, and the Moynihan Chirurgical, and so forth. And so, for him at least, we'd like to thank him, and I'll say thank you, Lord Moynihan, and thank you to you for listening.
Well, thank you, Neil, for a most inspirational lecture. I think there's nobody in this room would have been disappointed, and if Moynihan was here today, I'm sure he would join us in thanking you for a look into the future. A very eclectic lecture, actually, looking at legacy and what it means, and I thought that it had great ramifications for British surgery, particularly when you pointed out various hospitals shutting down, no longer there, and what's happening with reconfiguration and what's going to happen in the future, which is only natural. Surgery moves on. The robotic age is with us, and I think it's going to be very exciting. And I think the whole business about cancer surgery and how it's changed. And I was really impressed by the randomized control trials that you alluded to as well, which is so important now. And the fact that we are trying to organize research networks around the country. Sadly, that honorarium that you mentioned at the beginning that you were trying to suggest may continue to this very day, I'm really sorry about that. But what I can do is offer you a medal, which is the Moynihan Medal, which you richly deserve for everything you've contributed and for the superb lecture that you've given us today. We're most grateful. Thank you very much.
Thank you.
If you could now be upstanding, and we will process out of the hall. Fellow council members, President, ASGBI,